Symposium that has been sponsored by ViiV Healthcare. I do hope you've enjoyed the presentations that were made by our two eminent speakers, Professor Mark Cotton and Dr. Serufusa Sekidde. It really is a pleasure to have you both here with us today.
Thank you.
We will try to cover all the questions that have been asked, but given the limited time slot we have, should we not get to your question, please reach out to us separately. And I think we will start with Professor Cotton. So thank you, Professor Cotton. You gave a really brilliant overview on the evolution of pediatric HIV management. You covered the gains that have been achieved, and you also mentioned the still existing challenges that we face in the management of children living with HIV. In your presentation, you specifically called out the prevalence of resistance, necessitating the second and third line treatment. Would you share with us your thoughts on the progress that has been made towards newer pediatric HIV treatment options with a high barrier to resistance and the role that these treatments would offer, especially in first-line treatment?
Thank you very much. So, we've just heard about dolutegravir, which is, with really good data coming up, and it's surely going to make a huge difference as a component to treatment. You may be aware of the Odyssey trial, again led by DIGEB and through the Penta ID group, which is comparing in a randomized way dolutegravir based versus standard of care based therapy, and data is being looked at and will be presented within the next couple of months, hopefully. And so that will be a game changer. I do see a question about different delivery mechanisms, and what about the intramuscular formulations, and that's surely something to consider very, very seriously. The Impact Network is already working on this. There are some studies that are just about to open or have opened, starting with adolescents and hopefully moving to lower age groups. Whether an injection for a child every 3 months is the way to go or not, I don't know, but it certainly has a place. And one of the questions was about adherence, and with this from Caesar Magumba, would this actually be an option for areas where adherence isn't good? And I agree, that's really, really worth looking at and worth studying. In my experience, there are always issues with adherence, and those are often, there are many different reasons, and some of the reasons are difficulties in the family, difficulties with the mother, with lots of social pressures, making life really difficult, disclosure amongst partners, disclosure to the child. And in my opinion, it's often the mother as the main caregiver having to deal with this diagnosis herself and dealing with her own life and really coping in a very difficult world. So the best way to approach that is really good and insightful counseling by someone who's got time and who's got insight to speak to the caregiver and try to navigate the issues and the barriers in their lives. Of course, there are issues such as taste and the child not swallowing, etc. And these are issues as well that are already being addressed by these new formulations.
Thank you. Thank you for covering that very well, Professor Cotton. Clearly, that the new formulations are needed to address some of the challenges that we have existing in management of children living with HIV, such as the difficulty in formulations and adverse events, like you mentioned. And just speaking on some of the potential adverse events, I see a question coming in from Norbert, and this is to you, Serufusa, asking about He says, thank you for the great overview of pediatric DTG, but he asked if there's any evidence on any metabolic effects on children, including weight gain.
Well, thanks for asking that question, Norbert, and thanks, Michelle and Mark, for putting together this session, and excited to share around what we are doing. Norbert, on your question, I think the context around that is around the weight gain signal that we've seen in integrase inhibitors in the adult space. The key message before I get into the detail of it is to say that we need more data and studies to understand this signal in pediatrics, and therefore I think these should be ongoing and put in place. To get a little bit into the detail of it, the weight gain signal in integrases in adults, we've seen that in DTG and as well as in Biktarvy. We've seen that weight gain issue more pronounced in use, especially in combination with TAF. In the adult space, this is now reflected in our label, and we continue to do more studies to understand any of the factors that are around this, for example, genetic factors and other issues around that. As I said at the beginning, there are no or very few studies on this in the pediatric space, but I'm actually really excited that we will soon have data from Odyssey, which is one of the studies that was used to inform dosing and management of DTG in pediatrics that we recently put out and got a label for. And we expect that data to come out during CROI next year. So look out for that. But I think that's the key message from us in terms of weight gain in pediatrics. And I think also tied to that, I think there was also a question around just a metabolic issues. I think I'll specifically focus on the issue of insulin resistance, and to say that also once again here, the context that Norbert is talking about is the reports of DTG-related hyperglycemia in Uganda that we've seen, but also want to share that we've not seen that in either data sets, and we continue to investigate and understand the issue, and our safety teams are evaluating that. And once again, similar to what I've just said about weight gain, I think more studies need to be done, and we expect a couple more to come out soon, including the Odyssey data that will come out next year during CROI.
Thank you, Serufusa. So, Professor Cotton, just following on from what Serufusa has presented, would you share with us your clinical experience of patients you have seen started on DTG and how they've performed now that we're having the wide-scale rollout of dolutegravir?
Yes. So for that, I rely on my colleagues who are now at the coalface and treating patients, and who are switching to dolutegravir continuously for the last couple of months, and it's really going very well. So it's already happening, and children with undetectable viral loads are being switched, and it's I think everyone is very grateful for that. I wanted to just make a point about the weight gain, and also to just emphasize the importance of a good diet and exercise, and for all of us, and for the our patients, to encourage working on these important aspects of a healthy life.
Thank you, Prof. Cotton. There is indeed a multifactorial aspect, and there's still a lot that we don't know about weight gain in management of HIV. So switching gears just a little bit as we come to close to the end of this session. Serufusa, in your presentation, you talked about public-private partnerships that have been put in place to drive access to dolutegravir for children living with HIV. With almost 2 million children living with HIV across the globe, but only half of those having access to treatment, would you please tell us a little bit more about any access partnerships and the impact that this would make in Africa?
Yes, thanks for that. And I touched on one of the main ones that we are working on, which is some of the partnerships that we are doing with the Clinton Health Access Initiative, and who are partnered or funded by United to support quicker generic access within the sub-Saharan African continent. And some of you may have seen recently an article in the New York Times talking about how one of the products, which is the 10 milligrams cod tablet, has just been received tentative approval from the FDA which has been produced by Mylan, one of the generics. And so there are a couple of others that also coming up pretty soon. And we believe like this is a really strong way of making sure that there is effective, broad access to dolutegravir within the African continent. I mean, apart from that specific one, the other ones I'll mention are just the work that we and other originator companies and generics as well are doing with entities like PEPFAR and other bilateral organizations to ensure that there is access to these products in the countries.
Right. Thank you, Dr. Serufusa. So we still have a number of questions coming in, but unfortunately we have run out of time. I can see questions from Winnie, from James, but please reach out to us separately and we'll be able to respond to your questions. Thank you all for attending the session. I hope you found it useful. I hope you found it very insightful. ViiV Healthcare remains committed to leaving no child living with HIV or at risk of HIV behind. It has been a pleasure. Thank you, Professor Cotton and Dr. Serufusa. Your presentations were really insightful, as we can see from the numerous questions coming in. And thank you to all the different stakeholders who work tirelessly to ensure that children living with HIV globally are supported and that they're able to grow and thrive and live their best lives. So thank you, everybody, and thanks for attending the session. I hope you found it useful.
Thank you very much.
Thank you, everyone.
Bye.